we begin to understand that weight management, that weight regulation is really a biological process, and it led us into the bariatric surgery side. And I think it's important to emphasize that, my understanding of it, is that the modern bariatric surgery interventions are not either restrictive or malabsorptive. That's not what they're trying to do. They're actually rerouting food into triggering satiety signals and reducing the hunger signals. And so they are really surgical endocrine manipulations. And I'm so pleased that we seem to be gradually regaining the ground, Barbara, in terms of bringing it back into endocrinology and hopefully away from the surgeons because of the potential side effects of the surgery. But the surgery showed us that you can get sustained weight loss, as Rob illustrated. So we've got a couple of questions, and then feel free to the panel to jump in. Let's just deal with Katerina's first. So she says, is it possible to mitigate in practice addressing energy balance, e.g. reduce energy intake to lose weight while preserving leptin function? Now, I'm going to ask Sadaf maybe to pick this one up, but to me, this also raises the issue of, and I know, Sadaf, something you've talked about before, we have an incredible ability to choose our food. We know what we want, and it's intriguing how we know that. And so the idea, I guess, is this about tricking the appetite regulation system as opposed to controlling? What would you say, Sadaf?
So I think the basic premise is if that anybody reduces the number of calories they're taking in from what they need, and that could be acute fasting versus a calorie restricted diet versus sustained weight loss, your leptin levels will fall, and that will drive hunger and also the craving for food. The fact that food is more rewarding and you like it more. Can you trick or deal with that? Well, obviously a number of companies are looking to try to see if they can do something about that, and whether once that fall in leptin occurs, for example, whether you could give leptin or a drug that works like leptin to try to mitigate that response. The other thing is clearly how you deal with that response varies between people. So some people can manage that better than others. And that's in strong part, I think, down to the way your brain is wired. So I think the simple answer is you can't really deprive someone of calories or lose weight and not change leptin. You will change leptin. The question is, can you support that in some way and help people? And then I think that also really speaks to the question of drugs and medicines, because one of the ways that those drugs do that is that they change the tone of the system. So essentially you're reducing someone's appetite. That's how most of these drugs work, and you're making them feel full, but you're doing that pharmacologically.
Thanks. And I think that also brings in, and feel free, Barbara or Rob, to jump in. It brings in a question that's coming a bit further on, that certain foods, if you like, trick the appetite mechanism, and certain ways of eating trick the appetite mechanism. It's there designed to try and work out almost by minute how much food you eat during the meal and tell you to stop eating through the meal. So one of the points that's raised here is, which often comes up, is, Sadaf, you pointed out that everyone, this is an obesity epidemic. If it's a genetic thing that's predetermined, why is it that we're all gradually increasing weight?
So obviously our genes have not changed in that time. What has changed is our environment. And it is the changes in our environment, and in particular our food intake, that's driving the rise in obesity. But that's acting on a background of genetic susceptibility. So, it's like a bell curve, but actually the bell curve is skewed towards the right. There's a greater proportion of people with severe obesity. So for most people, we're eating just a bit more than we need, and that's driving the change in the mean BMI in the population. Some people who are genetically predisposed to gaining weight more easily in the given environment will gain a lot more weight. And the people who are genetically protected from gaining weight will generally stay slim. They might have been very thin before, but they're now tending to be normal weight. So it's the interaction between our environment and our genes that's shaping what we see clinically.
Are there, and I don't know whether, Rob, did you want to come in on this one?
Yeah, I was just going to say that, I suppose the other thing that kind of drives it is that there are some situations where we don't eat to our appetite. So that have crept into our life. So and have been helped by industry. So I was I noticed that when I was growing up, we never had snacks. Our children never had to have snacks between meals, and my mum never had to send me to school. And I frequently have arguments with my school about the fact that I have to send my child in with a snack when they're perfectly able to manage between breakfast and lunch and things. So there are things that have crept in that we feel that, and if you do get habits, then you continue those habits, and it's not necessarily all driven by hunger. They're just habits that are very difficult to break. And in children, I'm not seen it in adults, but in children's, I know that there have been studies that if you slow down the eating in children, that although it doesn't affect leptin, it gives them changes in ghrelin levels and other levels, and they then end up eating less. So some of it is the environment that we put in, that we eat without consciously thinking about eating in front of the telly, eating fast, rather than eating, enjoying, and also eating slowly. So there are some things that can be done outside that appetite that can help with weight.
Yes, and to me, the appetite regulatory system doesn't measure calories. It eventually leptin does measure calories when it's done all the calculations at the end of the day, but it's a bit like your tax return. It only sort of happens after a long period of time. But minute by minute, food by food, meal by meal, the appetite regulatory system is doing something else. And this is where, I just wanted to bring in the concept of fast food or calorie dense foods, that you may be able to consume more calories with less appetite effect. And maybe that what you're hinting at, Rob, in terms of what companies have realized, that that makes you able to eat more and want to eat more. I don't know if anybody wants to come in on that disconnect between calorie intake and appetite regulation.
So maybe I can kick off. So for sure, I think the points Rob made and you made there is that it's quite clear that the fat content of food specifically certainly promotes overeating, and also as not only the actual content, but what we learn about the fact that we ate something and we liked it. So the more you like certain types of food, and that varies across people, your brain will light up when we show you pictures of that food. So for most people, that's cake and high calorie food. There are some people for whom broccoli lights up the brain. They're a bit unusual, but that does happen. But actually, you can see in real time changes in the wiring and therefore the activation of the brain when you just see pictures of certain kinds of food. And of course, your response in the brain is also affected by things like advertising, by the fact that you learn that French fries go with the McDonald's symbol. And then the McDonald's symbol, whenever it's presented to you, encodes the same change in the brain, regardless of what it's paired with. So our habits and our preference for certain foods affects the brain and the wiring of the brain, which then affects our behavior over time.
I suppose the remarkable thing, sorry, Rob.
I was going to say, I think it's really interesting how much hormones have an effect, though, on some of our patient choices. So you can see there have been studies that if you present people a day after having bariatric surgery, different sweeteners of drinks, they have already changed to something that is less sweet that they find nice. So it's almost that the regulation happens instantly through the taste, through the system, which is really quite astounding to think that you're driven, because you think that quite a lot of that's habit, what you put in, but it's not. It's being regulated by something else.
Yeah, I think that's the most striking thing about it. I remember you describing once that in the kids before they have leptin, when they're leptin deficient, they'll eat anything, and after the leptin, they don't want the broccoli anymore and they want their cake. So it's a very sophisticated system, actually. I'm getting carried away with the things I enjoy about this, but let's get back to the questions here. So Neil's asking, obesity, like smoking and some other key CV risk factors, is very unevenly distributed by deprivation score. Do we really understand this? And if we did, we might be able to exploit it in terms of therapy. So, it is now in developed countries that poor is fat and thin is rich. Who wants to have a go at that? Why does that happen?
I mean, it's, I guess it's a lot of deprived areas because of the poverty, that the quality of the food that you eat will be obviously less nutritional. So, people can't afford to buy good food. They can't afford to buy vegetables and high rich good quality food. So I think to some extent, for sure, that will be driving it. Perhaps education is a factor as well. So those are all factors that will be affecting the fact that deprived areas have a much higher prevalence of obesity.
It's interesting you use the word nutritional. They're clearly very nutritional because they're packed with calories.
The wrong sort of nutrient.
Exactly. So that's the interesting thing, is that it seems that maybe cheaper foods or more available foods are more calorie dense and are able to, at least the way I see it, get around the appetite regulatory system more efficiently than eating, what you describe as more nutritional foods.
And
I think the other thing is that it's one of those things. Once you're in that position, it's much more difficult to get out of that situation if you're overweight, because you don't get the opportunities that other people get. Particularly females, you're much less likely to get promoted in certain jobs and things. So you have this kind of escalation. If you start and you're trying to escape from that deprivation, it's so much harder if you have a weight problem than if you don't have a weight problem. And that's society's problem, is the way that they view these people.
Yes, exactly. I'm just noticing that some people are putting questions in the chat, just to encourage people to use the Q&A, because otherwise I have to look in two directions to catch your question. So I will come over to the chat questions in just a moment. I'm going to pick up one more from the Q&A. It's great to see all these questions coming in. So Tom Hockaday says, while the set point for weight has a large genetic component, how much do fetal or infantile experiences also affect it? So I don't think anybody's talked about that. Who wants to pick that one up? Sit up.
So maybe I can pick it up. So, there's been a suggestion for a long time, mainly from epidemiological data, linking low birth weight with subsequent risk of metabolic disease. But that's epidemiological data, and causality is a different thing. Now, there is data in animal models that the uterine environment, and therefore the nutritional state of the fetus, can affect the child of the animal when it grows up, both in terms of its metabolic disease, but also its appetite and other things. So I think it's quite likely that their exposure to the fetus in utero affects subsequent risk of metabolic disease. It's quite hard to prove it, though. It may be one reason why some people get metabolic complications. For example, one of the potential explanations for why in the US a lot more children were getting fatty liver disease, type 2 diabetes, etc., when we were 20 years ago, when we were not seeing that in the UK, is that they were effectively in advance of us. And so their mothers were much more likely to be obese. And so the children may be more at risk of getting metabolic complications. So potentially, yes, evidence for that still quite limited.
Yes, I quite like the story of, the Dutch famine story, that when the Germans cut off the supply because they were disrupting the railways, that they had a huge famine there. They ended up having small babies that were born at that time, and they've increased their rate of diabetes. Because as I understand it, you've only got a limited number of fat cells. And if you're born during famine, you maybe have less fat cells. And once you fill them up, you're going to get metabolic problems. So maybe, is that part of the link?
There's no evidence for that being part of the link. You do have a certain number of fat cells, but we know, and it's generally when you gain weight, you put more fat into each fat cell, but you can actually increase the number of fat cells too. So some very elegant studies done by people in Sweden who do effectively carbon dating of fat cells. So you can tell when they developed, have shown for the first time that actually most of obesity is accumulation of lipid in your existing fat cells, but you can, after a while, even make new ones. The problem is once you've made them, it's very hard to get rid of them.
Great. Okay. Now, I mustn't get carried away with myself again. So now there's going to be some questions about energy metabolism in a minute, but let's just go over to the chat for just a moment. Hold on a second. The question on intermittent fasting, Rob, I think you may have picked that up, but how does that fit in? Is there any evidence that intermittent fasting is more effective? Does it have a biological basis?
So, I mean, what we're meaning by intermittent fasting is, so there's two types of intermittent fasting. One of them is that you on a, and it's not really complete fasting, but it's the 5-2 diet, where you have 2 days a week where you eat 500 calories and then you eat the rest of the time. And what you're hoping is that you don't increase the calories on to compensate for the fact for those 2 days that you had 500. But because you've only had them for 2 days, hopefully the hunger doesn't seep in and cause problems and things. There isn't that much data for it. It was originally designed for people who were overweight or coming up for breast cancer operations and things. So there's not that many good quality trials out there, but it does seem to work for some people. Find it a way that they can get a bit of weight off, but again, nowhere near what we're seeing with surgery and other things. And then the other diet that's come into fad much more is that you only eat during a certain period of the day and then you don't eat after that period of the day. Some of those you have to get all your food in before sort of 12 o'clock, and then you have nothing from 12 o'clock onwards to the next day. And again, I'm not sure that the evidence is really clear that's of benefit in terms of weight loss. It can, though, help with some of the metabolic things like your glucose and things. There is some evidence that it will drop your fasting glucose, as you can imagine, if you're fasting longer and things. But there's no real long-term data on that I know of.
And I'm not sure it makes complete biological sense, but it'd be nice to know. So Stuart Rosen says, are there any data combining surgery and the most recent drugs? I think he wants us to lose 60% of our body weight. I'm going to ask Barbara to come in on that one, if that's okay. I mean, do we need to combine the two and have people combine the two?
Thank you. So we haven't really had large-scale clinical trials, although there have been some trials, and certainly I was involved in one of these, adding liraglutide to GLP-1 in patients who still had type 2 diabetes post-bariatric surgery, to assess whether they would perform better, both in terms of HbA1c and weight loss. And indeed, adding actually GLP-1 therapy did show benefit both in HbA1c and some greater weight loss. So I think there is scope for adding medication post-bariatric surgery, and certainly in patients with weight regain. And we do see this in about a third of our patients, where what are the options? Well, we can either think about revisional surgery. It depends on the type of surgery that they had in the first place, or adding pharmacotherapy. But I think the long-term evidence is lacking, and I think we need more clinical trials in this area. But certainly, I think it's something that we will certainly see over the coming years.
I mean, sorry, I was going to say, from a necessity point of view, sometimes we've had to do an order that we've used all the modalities just to get people safely through surgery or lose enough weight. So if we have someone who has a BMI of 80 or 90, sometimes we've had to take them through diet, then GLP-1s, getting them ready for surgery, and then having surgery. So there are people who out there have kind of had combinations of everything to get them to a safe weight. But yeah, it's the long-term kind of data that we don't have, isn't it?
And that's raised for me the question of quality of life. I mean, I don't run a bariatric surgery service, but I have the impression that some people are fairly miserable after bariatric surgery. And I've often wondered why that would be. You might think they would be delighted. And I just wondered what your comments are about that, and also how that compares to weight loss with drugs, with these kind of drugs. Barbara, do you want to go first on that one?
So I don't think we are at the stage yet where we've sort of done clinical trials comparing the drugs, versus the bariatric surgery. But I think, that will come, because, as I mentioned, we're now getting close to the sort of weight loss that we are seeing with bariatric surgery. In terms of outcomes post-bariatric surgery, like I said, bariatric surgery is not a surgical intervention as, in the same way as if you take your gallbladder out. We need to address the psychological aspects, the anxiety, depression, the binge eating, behavioral aspects, which, lifestyle intervention, sleep, everything. And so all of these have to be carefully assessed, considered, and managed to ensure that outcomes post-bariatric surgery are the best that they can be. And that's why it needs to be done, by a multidisciplinary center with a multidisciplinary team to improve those outcomes.
You don't think that bariatric surgery takes the fun out of life? if you want to look at it. I mean, food is part of our enjoyment, and is that what some people are suffering because it was an important part of their life? Or?
It's a really good question, and absolutely for some people, you are right. We love eating, we love our food, and if, taking that away can cause more depression post surgery. But I have to say that for the majority of patients, I mean, bariatric surgery is life changing, and the majority of patients are delighted, with the weight loss and the improvement in health. Of course, like I said, we need to be careful because there will be some patients who will, like I said, who do depend on it. For example, absolutely. And so they need to be carefully advised, because, like I said, they will not feel hungry after surgery. As you know, that's the reason why they lose weight. There are clearly biological changes, and it is a huge life change.
Well, yeah,
I think some of the problem is that the people that we in the UK that we get for surgery are very complex people that have a lot of things going on. And the expectation, I don't think, has ever been that we are going to solve their problem. So there's a very famous Canadian who said that in general, surgery on a health service doesn't make happy Kens and happy Barbies. In other words, they when they lose their weight, they have problems with excess skin, but they also aren't particularly happy because of other things that have caused them to gain weight and things. But if you pull out the people who don't have huge complications and other psychological problems going on, I think there's pretty clear evidence that people who have bariatric surgery get as good, if not better, quality of life than people in diet trials. It's just the fact that it's very complicated by the way within our health service. We almost say you have to be incredibly unwell or incredibly stressed and before we're going to let you have surgery. And that's wrong, but in my opinion.
So I think that leads into Christian Dellis's question. And it's back to this question that Sadaf, I think, began to address, which is how we view it. Is it your fault that you're fat, basically? Is that the lifestyle issue part of that? So he says, would it be fair to say that environment, lifestyle, hormones, etc., are the main drivers for this, or would you see a major genetic component here as well? And I'm probably reading too much into Christian's question, that if it's genetics, it's not my fault. And if it's environment and lifestyle, maybe it is. Sadaf, do you want to pick that one up? Which is the right balance here?
So the question relates to midpoint, gaining weight in midlife, actually, and how far that is down to different factors. So let me take that bit first. So it is quite clear that, of course, people gain weight in midlife, and that's the fact that you see that across populations of different ethnicities in different countries is very clear, and does suggest that there are biological factors underpinning that. So, and of course, the pattern is different in men as it is in women. And of course, it changes quite dramatically after the menopause in women. So there are clearly biological factors that affect midlife weight gain. We don't actually know much about them other than the obvious changes in male and female hormone levels. So in terms of what is the main driver, I think, it's both things together. In some people, there's a very major genetic driver, and it may even be entirely genetically driven. That's a smaller number of people. In most people, there's a combination of genetic drivers and environmental factors. But of course, our genetic drivers influence how we interact with the environment. So our genetic drivers give us a bigger appetite. If the food we then tend to eat is higher in calorie and we're not very well off, then that's us interacting with our environment in an adverse way. If we have a big appetite and we're eating healthier food and we're managing to, because we're well off, go to the gym and do something else, we may not gain as much weight. So it's quite like a lot of medicine. It's down to a combination of things. And, I think it's more about assessing the patient and the person in front of you and trying to weigh those things up.
And it's interesting across cultures, and, I think there's a strong correlation between body weight and speaking English, as I understand it. So, the Anglo-Saxon cultures often have similar genetics to France and Italy and so on, but have very different BMIs, don't they? I think that suggests that there are these kind of cultural factors beyond genetic. Rob, yeah.
Yeah, I always struggle with this question because I don't think it really matters. And I know that seems a really strange thing to say, is that as a health service, we should be treating no matter which one it is, and we should be treating it with empathy. And it always kind of reminds me of kind of when I did my oncology rotation, is that there's people who sit in the oncology clinic who have purely genetic causes of their cancer, and we treat them. And there are people who don't have those genetic causes and actually are at reasonably low risk, but because of the awful lifestyle that they had in terms of smoking and other things that they've done, get cancer. And we don't differentiate whether we treat them or not. And we need to move away from what fault is it, whose fault is it, and say, this is a group of people who are at high risk of dying, high risk of problems, and we need to be empathetically treating them and stop kind of having this discussion about whether it's their fault or not their fault, and just get on and treat them. But
well said, well said.
Okay, thank you very much. Lots more questions. So how much does brown fat contribute to body weight regulation in childhood and in adulthood? And of course, that brings back in the issue of metabolic rate. I mean, it's my understanding actually that metabolic rate does fall as you get older. At least I'm accusing that as being quite an element in it. And we've managed to studiously avoid exercise in this discussion almost completely. And in my view, that's appropriate because exercise is a very difficult way to lose weight. But who wants to have a go at brown fat and maybe metabolism in this?
Okay, shall I? I'll start. So brown fat, obviously, we now know, because we can measure it and visualize it, is predominantly there in children and infants. We have some as adults. It varies hugely in the amount that people have, and it's unlikely to contribute significantly to weight regulation. It does, of course, contribute to thermogenesis and heat generation, and that's much more relevant in infancy and childhood. However, there are companies trying to see whether we can, if we understand how much brown fat is generated, and if we can turn up the dial, can we actually allow people to burn more energy? The problem is, can we do that safely? And that's the thing that we don't yet know.
Yes, for me, it would be the next webinar, which is, can we eat what we want? I mean, we said we could be what weight you like, but obviously that would be an issue.
So we're working on that. One of the ways that we're working on that is we're studying people who are very thin. So we've got a cohort of 3,000 people who have got a BMI of 18 that we recruited with the help of colleagues in general practice across the UK, who are very thin. And many of them tell me that they can eat what they like and they don't put on weight. And they have a strong family history of thinness. Now, really, the question is, can we find genes that are driving their thinness? And I think if we do, we'll be able to answer that question.
And you're implying that that would be less appetite driven than the obesity?
Well, again, we see a spectrum. So we see some people who have small appetites and they're not interested in eating, but we have others who, and we've even tested them by bringing them in and making them overeat. And then they still don't gain weight. So we're thinking that there may be other mechanisms there.
Great. So I want to bring in Julian Knight's question. He's asking, is there a role for epigenetics in this? I guess that might come back to you as well, Siddharth. If anyone wants to add into epigenetics.
Epigenetics. A lot of people ask about epigenetics. Simple answer is no direct evidence in humans as yet. Some suggestion of mechanisms in mice, whereby particular regions you can change the epigenetic marks, which then influences the weight of offspring. So potentially, theoretically, no evidence yet in humans.
Okay, so does the brain-specific region in response to fat or cake vary with MCR4 variants, or is that across the gene variant spectra? So is there a gene for cake? So the brain regions are the same, and those brain regions are the regions of the brain involved in reward, which are similar to the regions that are activated by other pleasurable things like alcohol, smoking, etc. So the regions of the brain are the same. There is a difference in the signal with particular genes, and even with leptin. So you get an incredibly strong signal in those brain regions if you have no leptin, or if you're fasting or you're starving. Those brain regions light up compared to if you're fed or if you've had treatment with leptin. And in people with MC4R, the commonest gene, they have a much stronger preference for high-fat food. In fact, 90% more than people who are lean, and 70% more than people who are obese. So there are differences in the strength of the response, but the brain regions are the same. And of course, it is in the hypothalamus. It's in the region that is integrating all sorts of other signals, isn't it?
Yeah, there's a strong link with dopaminergic neurons. So, for example, we know that dopamine is key to reward and to liking things. And those neurons are intimately connected with MC4R and hunger and satiety. We also know that the opioid system, which is really keen for wanting the motivation to have alcohol, food, drugs, is also closely linked to this pathway.
So John Isaac says, are there lessons for frailty also? As we age, we lose weight, particularly muscle mass. Whilst this is likely due to inflammation, could it be manipulated using the same hormones we are discussing? So I think that begins to introduce the idea that we could use this system to increase body weight. And I'll just toss in the question of anorexia in there as whether that's a condition that we might be able to treat biologically rather than psychologically. Okay, who wants to have a go at reduce changes in body mass as we get older?
So maybe I can kick off with one bit of that. So actually, there is a lot of interest now in the pharmaceutical industry in targeting these same pathways for beneficial weight gain in the elderly. So that's certainly possible, and that those things are being considered. And in addition to not just increasing appetite in people in whom you would want to increase appetite, and muscle mass and fat mass. So the elderly, frail, potentially cancer, cachexia is another area where there's a lot of interest. And then the other kind of big area that I think has not really reached physicians or clinical practice yet, but I think will do, and that is the finding of what are adipokines, but adipomyokines. So that is hormones made by muscle. So we're now realizing that there are a whole bunch of hormones released by muscle cells, and there is a lot of crosstalk between fat tissue and muscle cells. And some of these hormones and their receptors could be targeted to build muscle strength. So I think there's an awful lot of potential for development in this area.
I mean, I always find it quite difficult, the kind of the loss of weight as you get older, because there's obviously lots of other factors are going on there. One of the factors is you're becoming a bit more insulin resistant because some of your hormones are dropping off, and we know that if you make muscles insulin resistant, then they find it harder. They kind of break down more than they make. And then obviously there's the change in patterns of what happens with your exercise. So we know that when people retire, a lot of people, their exercise levels fall, or they only do it intermittently, that they kind of go for the paper in the morning, and then in the afternoon, nothing happens. And you can clearly see that when you measure activity things. So it's very difficult to know what kind of balance that is to do with appetite regulation, everything else, or whether it's the lifestyle and things that are going on and things. I mean, one question that I had just on that MC4 thing, while we were just sort of thinking about it, if I'm allowed to ask a question, was obviously there has been a story, because it's one of the things that we do see in clinic, of people who are treated for mental illnesses, that they get drugs that help with their mental thing. Is it true that there is that can confirm whether people are likely to gain more weight with these drugs or not? Or because there have been kind of...
Yes, that's a really important area clinically, as you say, Rob. We're all seeing patients, for example, in diabetes and obesity clinics who are being treated with the newer generation antipsychotic drugs, for example, where there's a high percentage of people gain weight and also develop type 2 diabetes quite rapidly. So, and in fact, to the extent that it can then compromise using their antipsychotic medication over time. So there's now some good evidence that many of those drugs, like olanzapine, for example, the reason for their weight promoting effects is that they antagonize the serotonin 2C receptor. And that's on this same melanocortin neurons. And in fact, we've got a paper coming out, I think maybe tomorrow even, on human mutations in the serotonin 2C receptor. So patients who have mutations in that gene develop obesity from a young age. They also develop social anxiety. And we see the same in mice that have a problem there. So yes, I think we can clearly now understand why so many of the people treated with those drugs develop obesity and diabetes. Hopefully, we can then develop slightly better drugs. The problem is many of these drugs affect signaling through multiple different receptors at the same time. And so whilst you get beneficial effects on mood or psychotic features, you also get weight promoting. So, I mean, I'm hopeful that a better understanding of exactly what's going on might lead to better drugs, because they're certainly effective at one aspect and not the other.
So lots of questions, and I'm afraid there's a few that we haven't answered yet, but in the interest of time. But I think what you're responding to there is the remarkable thing that using the kind of physiological mechanisms of the appetite hormones coming out of the gut has appeared safer and more effective maybe than direct targeting of the receptors in the brain. And the older drugs often cause things like depression and suicide and so on, because they were acting on more brain systems than perhaps they were designed to do with the gut hormones. So I just want to take this opportunity to thank everybody who's participated in a really lively discussion. I hope you found it interesting. We haven't really got on today to talking about the medical benefits that now can be realized, but I think you're beginning to visualize that this incredible new understanding of the appetite regulation system, particularly, maybe metabolic regulation, that's a separate issue, is allowing us to make very major changes in a disease that's existed and has affected many other diseases in terms of its impact on bodily systems. So we expect to see major changes going forward and excitement for new innovation in this area. And look forward to Siddharth's paper that's coming out tomorrow. So we can enjoy it. So thank you to all my presenters. This is recorded so people can go back and have a review. There's lots of richness in the conversation that we've had. And I hope you all have a great festive season as well. Thank you all.